Today I'm going to talk of a quite innovative concept, which is the possibility to re-explore surgical aspects after you've done some other treatments to cure the disease, in this case melanoma, which is characterized by specific situations which before the development of new treatments that now we have available, we could not think about offering after the treatments the surgical opportunity to these patients. Now that there are treatments which are effective, you can obtain a situation where maybe surgeons like me can come back to the bed of the patient and propose further treatment from this point of view. My presentation is divided into the different stages of the disease. So we start with clinical situations on the primary melanoma or on the large primary skin cancers, where the only alternative could be a major surgery, which goes also to amputations. If the primary disease is, for example, on a foot, I'm presenting two cases of patients with large primary tumors, which from the surgical point of view could not be just resected. The resection would imply also the demolition of part of the body like the foot or the leg. And my first part of the discussion is in fact dedicated to the possibility to do a treatment before. One is the limb perfusion, which is a treatment that isolates the vascularization of the limb, and you create an extracorporeal circuit through which you isolate completely the blood stream of the district that you want to treat, which is the limb. In this way, you can introduce into the circuit a very high concentration of drugs. You raise the temperature of all the system of the blood, and the combination of this high temperature and of the anti-tumoral drugs obtains a very important anti-tumoral effect. And in fact, the tumor shrinks, and then at the end, after 2, 6, 4 months, you can do a very limited operation to resect the residual of the disease, if there is any residual of disease. The other approach I'm proposing is electrochemotherapy, again on large primary melanomas. And again, this is a local regional treatment, very, very effective on specific situations. And the cases that I've been treating with this approach on primary melanomas have given us always very good results in terms of conservation of the anatomical structures and of efficacy against the tumor. And this is, you know, a very particular situation. So far, it's not, I mean, nowadays it's not so frequent to have large, huge primary lesions because people finally come a bit earlier than it was 50 years ago to get a patient's advice, a doctor's advice, but sometimes it happens. And when you find these situations, the alternatives are either, as I said, a major surgical procedure, or you have to invent something different. And these approaches can offer us a conservative methodology of treating our patients. The next step for the treatment of this disease is the situation where we have to treat patients with the so-called in-transit metastases. These are tumoral lesions that develop along the lymphatic stream in between the primary disease and the locoregional nodes. If you have this kind of progression of the disease, your quality of life is deteriorated, and your prognosis is certainly worsening. And here my presentation starts with the concept that we have probably more questions than answers to offer to solve this situation. And this is because we don't have so many studies to say what is better first. Is it better to start with the loco-regional approach, like the ones that I was mentioning before for the primary disease, or is it better to start with a systemic treatment? And it's a difficult answer, because if you start with the new effective treatments and the disease is only limited to the skin, then in case in the future of the life of the patient he would develop visceral metastasis, brain, lung, liver metastasis, what would you offer to this patient? On the contrary, we think that if you treat these patients with these systemic treatments, which are the checkpoint inhibitors, which are the target therapies, which are finally effective in melanoma, if we treat these patients with a limited amount of disease, it's probably better than if you treat these patients with larger and bulky tumors. So, you know, it's something that we don't know. What is the solution? Well, the solution is to discuss it with patients and with all the colleagues involved. So you need to be a surgical oncologist, you need to be a medical oncologist, you need to put the radiologists and the pathologists into a room and discuss the various options that you can offer to the patient. And then, in front of the patient, you have to show the different offers, the different treatment modalities that you can prepare and you can propose to him. And then at the end, the decision has to be taken in between the doctor and the patient himself. Because if you don't have anything to say, this is better than that, I mean, and everything and a lot of options are at the same level, the only thing that you can do is to discuss it with the patient, and then from his point of view, you will try to modulate the better decision for him. Then there is the situation where the patient presents advanced disease. So it's the so-called stage 4. Stage 4, which means the presence of metastases to different parts of the body. And here, this surgical option has been always the only one before the era of the new drugs. This was the only option, but the only option when it was feasible, because the alternative, when you had really several lesions everywhere in the body, was to do chemotherapy with an efficacy of 5% of survival at 5 years, so very, very limited success. And now we can start to say that at least half of our patients may be able to survive. We have the evidence of the durability of the efficacy of the new treatments. The point, again, comes when you have these situations of patients who have obtained a regression, not a complete response, but a regression, a partial regression of the tumor. And here again, the surgical approach can be proposed. So, you know, you come back to the surgeon with a medical oncologist to discuss each single patient who may benefit for a resection of the residual of the disease, who may not have completely disappeared with these new treatments. And this, you know, it's a very new situation, because until 5-6 years ago, we didn't have any patient, I would say, who is alive with limited amount of disease after the treatment. Either you had very few patients, anecdotal patients with a complete response, or you had patients progressing. But very, very difficult was to say that we could have patients who had a situation, an inoperable situation at the beginning, they had a treatment, and they reduced the tumor at the situation where the surgical indication could be proposed back. And this is what is instead now happening. Of course, we don't have numbers, because it's something that we are seeing since few years. And statistically, we don't yet know if this surgical indication would really help in improving the survival of our patients or not. We'll see. It takes time to get the numbers, to get the experience on this kind of situation, but certainly we are discussing back patients also from the surgical point of view after they had been treated from the medical point of view. The advice is always that melanoma patients and skin cancer patients should be treated in a multidisciplinary setting. It's important that these patients are referred to an academical institution where you have dedicated doctors. Don't treat patients in a naive way. One of the slides I'm presenting, it's a slide coming from a plastic surgeon in a peripheral hospital in Italy. He showed us these slides where he made major resection on a limb of a patient. But this was due to the presence of the so-called in-transit metastases on the limb of this patient. He made resections as much as large as this, which is totally unuseful because you perfectly know that the next day that the skin graft has healed, this poor person will develop other in-transit metastases just aside, and you have destroyed half of the leg of a person, which is totally absurd. So really think not as good as you are the best plastic surgeon in this case, but think about treating patients from a global oncological idea, and not just because you are the best plastic surgeon, do a devastating surgery because you know how to repair it. Because from the oncological point of view, you have done nothing good to this patient.